So moving on to management then, we've already talked through the A2E, but as we well know, the A2E is both an assessment and a management of the patient. So as we're going through our A2E, we might pick up on that life-threatening airway swelling that we've mentioned. So you might have the skin and might have the tongue swelling, might be some stridor, or all of those things that Hugh just mentioned. And I think it's important to mention at that stage that you have an airway problem, so you have to treat the airway problem. So I think it's partly our fault when we, as medical educators, that when we teach A2Es, we teach them that treating an airway is oxygen and it's Gardels and it's nasopharyngeals and it's head tilt chin lifts and yada yada yada. But actually, in anaphylaxis, IM adrenaline is the way that you treat the airway problem. Okay, that will help reduce that swelling.
Sure.
Will improve that airway problem pretty quickly. So I think it's important that students kind of get that in their head, that medications are airway interventions as well. I always mention when we talk about this, croup is the other classic. So the stridor that you get in croup, treat it with some dexamethasone, treat it with budesonide, whatever you need to do.
So I think what you're saying is with anaphylaxis, you want to get treatment in as early as possible.
Oh yeah.
And that's, I think, because, as Laura was saying earlier, it does progress so quickly that actually the more you delay it, the worse the outcome will be.
So what are the key features then, Laura, of management?
So obviously, as we've already alluded to quite heavily in when we're talking about airway, IM adrenaline, 1 in 1,000 IM adrenaline is your number one drug that you want to get in as promptly as possible once you've recognised an anaphylactic reaction. So just a bit of background about adrenaline. So its main action is via alpha receptors, which cause vasoconstriction, which help counteract that hypotension that you can see in anaphylaxis. It also has beta action, so it helps cause bronchodilation, reverting that bronchospasm that you may also have seen in your patient. And at your level, sort of F1 level, you would only be giving it IM. IV adrenaline is also available, but you certainly wouldn't be giving that without senior supervision and advice.
Strongly agree with that point. It does happen in sim quite a lot, actually, where because they'll go for the adrenaline, which is in the emergency drugs in the resus trolley, and they just semi-panic, and you go, I've got some adrenaline drawn up, and that's the IV adrenaline, which is for PEA arrests. It's not for anaphylaxis. As you mentioned, you can give it sort of ICU, ED, sometimes, those high sort of high dependency areas, but there has to be someone who's really experienced with it, and I've never seen it used in practice, IV adrenaline for anaphylaxis. If given, it does cause significant arrhythmias and can cause cerebrovascular hemorrhage or infarction. So, just be very cautious and make sure you go for the right adrenaline.
Don't believe Pulp Fiction.
Don't believe Pulp Fiction. I do love that. The whole Hollywood thing of intracardiac injections of anything is just brilliant. Outside of a cardiac tamponade, there's no real reason to stab somebody in the heart. But no, it's always good to see. So we kind of mentioned a bit of a human factors point there, Hugh, that we often get the IM adrenaline and the IV adrenaline mixed up. Is there a way we can get around that?
Yeah, so I guess quite a good way that hospitals around the country have come up with overcoming those human factors that we were talking about is the anaphylaxis pack.
Yeah.
So that is available in all good resus trolleys near you. Essentially, it's in the bottom drawer, and it'll have the anaphylaxis guidelines. It'll have the key drugs, essentially. So it'll have the chlorphenamine, the adrenaline that we've been discussing, and some hydrocortisone as well. If you follow through the guidance, it becomes very clear that actually one of the earliest things you should do is call for help.
Yeah, call for help. And the other key point is the positioning of patients. Because again, that's something that we mentioned in a little chat before, that a lot of the time our students will sit up SIMMAD because they've got a bit of a breathing problem as they're working through their A2E. And actually it's probably not particularly helpful for the patient. And actually the anaphylaxis guidelines recommends laying the patient flat and raising the legs because the blood pressure is the primary issue. Now you can put these patients in a bit of a V if there is a significant respiratory component, but I think if in doubt, do what the guideline says, which is lay them flat and raise the legs up.
And just the thought process behind that is essentially to maintain perfusion to the brain despite the hypotension. Because what you really don't want to do is reverse the anaphylaxis reaction, have the patient, getting better from that point of view, but also having a hypoxic brain injury and ending up in ICU.
So we've mentioned a couple of other medications that are really important in the anaphylaxis algorithm as well. So chlorphenamine, which is our antihistamine agent, in a sort of emergency situation, if they happen to have IV access, you can give it through a slow IV injection. But obviously, IM preparations are also available in that situation. And I would highly recommend going for IM if you're in doubt at all. And also, it's hydrocortisone, so your steroids, also available as an IM injection, which is, although it's not acting immediately on the patient, it's really important to get early steroids in to help with that biphasic response.
Yeah, because it's quite good at reducing the risk of the biphasic response that we mentioned earlier. There's some new evidence coming from America, some studies going on about there. Because currently we use hydrocortisone or prednisolone orally, apparently. I've never seen anybody in anaphylaxis give bread. But apparently that's what we use in the UK. But America are looking at using dexamethasone. It's a much longer half-life.
Okay.
Certainly in children, apparently there's good evidence that it reduces that biphasic response significantly. Although that's not current UK guidelines, that might be something to keep an eye out for. And then mast cell tryptase is the other thing to consider. Once you've sort of managed that emergency, you've done your A2E, you've escalated care, you've got your guideline, you've got your anaphylaxis pack, you've gone through the whole shebang, they're feeling better, they're like, brilliant, can I go home? You go, no, you can't.
Absolutely not.
Why do you say no?
No. Just no. No, so you can't go home for two reasons. Firstly, the biphasic response that we mentioned, so normally within a couple of hours, up to like 2 to 6 hours really, you can get the biphasic response where you have a second anaphylactic reaction. And the other key thing is you want to do a mast cell tryptase. Mast cell tryptase is something that's released during the reaction itself, and you can measure it in the blood. So peak concentration is about 1 to 2 hours after the initial ingestion of the antigen responsible, and so you want to take a blood test ideally 1 to 2 hours after that. And in practice, we generally take one about 24 hours afterwards as well to see the trend of the mast cell tryptases. Now, you don't need to wait for the results because they take about 3 weeks to come back, but it's important for ongoing management, such as for GP follow-up and for allergy clinic follow-up. I suppose that's the other sort of point while we're on that. So when you do discharge these patients, often from emergency department, you need to send them home with some written advice, an adrenaline auto-injector. So if it happens again, you need to train them how to use that. It's generally just stabbing in the thigh. And an allergy clinic referral. So you need to send them to an appropriate allergy clinic where they'll have some allergy testing, further information about what's happened if the reaction.
It's also good in those circumstances to let the patient know that there is actually an expiry date on EpiPens. So that's one of the things that came through. I think there was a child who passed away at a school in London very recently, and one of the issues that they had was the EpiPen available at the school was actually 8 months out of date.
Something that I experienced when I was working in ED is that a lot of patients who had previously had anaphylactic reactions and had come in having had used their adrenaline, their expectation was to go home with a course of steroids, where in actual fact there is no proven benefit to providing courses of steroids post anaphylactic reaction.
Right, so that's basically all we wanted to talk about. I think we've covered anaphylaxis pretty well there, guys.
I'd agree, yeah.
I think we should probably end there with a summary point, maybe summary point each. Does that work?
Yeah, let's go for it.
Well.
When you're diagnosing anaphylaxis, it's really important to remember those 3 key criteria. So if it's acute onset illness with sudden progression, are there skin or mucosal changes? And if there is a life-threatening ABC problem, then anaphylaxis is likely.
Okay, I guess my take-home message, the route that you give adrenaline, always give IM, don't give IV, particularly as you are going forward into F1, F2. Don't even let IV come into your mind. It's made particularly easy by the fact that there are these anaphylaxis packs.
Yeah, so that's probably going to be my take-home message is use the anaphylaxis pack, use the guideline in it particularly. Make sure you follow what it says, lie the patient flat, raise the legs up, call for help early. Follow the algorithm. Don't try and be clever. I think I said to you guys before, the art of good emergency medicine is not trying to be clever and following a good guideline.
It's always a good take-home message.
Yeah.
Do not try to be clever.
Hashtag University of Exeter.
Hashtag tomorrow's doctors.
Fine, so it's witty sign-off time. Has anybody got a witty sign-off? Because Joe normally makes me do them. But,
No, Hugh had a good one.
Did you?
Do you want to share?
Got good?
I was just going to say that we'd been all over that like a rash.
Oh, that's quite good. I got my adrenaline pumping. I don't know.
Oh, zing. Round the circle.
And I don't have one. Sorry, guys. Better luck next time.